Hello, everyone. Thanks for joining us today for Q&A and latest updates on COVID-19 telehealth regulations. We'll have a brief presentation followed by the Q&A. To ask a question, you can type it into the questions box that you see on your screen. And in the box at the bottom of your screen under the slides, you'll see that you can download a PDF copy of today's slides. We are recording this webinar and we'll post it on our COVID-19 telehealth page, which you can access by going to our website, diabeteseducator.org, and we'll have a direct link for you at the end of the webinar. With us today are Chris Keelan from the Billings Clinic in Miles City, Montana, Patty Telgener, Vice President of Reimbursement with Emerson Consultants and ADCES's reimbursement expert. And from ADCES, we have Leslie Kolb, Chief Science and Practice Officer, Sasha Ullman, Director of Diabetes Education and Prevention Programs, and Joanne Rinker, Director of Practice and Content Development. So I will throw it over to Joanne to get us started.
Thank you so much. First, I just would like to welcome everybody to our Q&A session. We'll jump right in, and you see here I just left the telehealth resource page on this slide deck. And one thing that I wanted to mention about all the Q&As that we've had over the last about 6 weeks, they are all available on the website, the recordings, as well as the slide decks themselves. And I say that because you'll be able to access links that way, and so even when you know you just want to go back and find a link, you don't have to go through the recording. You could go directly to the PowerPoint slide deck itself. So with that said, again, there's the link to our telehealth resource page. And then these next set of slides that I'm going to kind of scroll through, Patty's going to talk a little bit with a high-level overview. Before she does, I just want to make sure everyone is aware that, you know, we are interpreting and sharing this information, but we also want to be sure that you share this information with your organizations so that you can make individual organization decisions. So Patty, I'm going to turn it over to you to give us a little overview of these next six or seven slides.
Absolutely. So thank you. And I think these links are going to be extremely helpful because what we're seeing is CMS, as well as the private payers, as well as most of the Medicaid programs, are all trying to adjust under this kind of COVID-19 crisis. The links that we are providing will tell you specifically how each payer is handling that, but we did want to just provide some kind of common themes that we're seeing. One, for both CMS as well as the private payers, we are seeing some advanced payments going to hospitals or providers, realizing especially those hospitals that are more on the elective surgery side and not directly COVID related, they are under some significant financial crunch. So again, CMS and some private payers are trying to give some advanced payments. I'm seeing a lot of payers removing prior authorizations or removing some of those concurrent reviews. Also, another kind of consistent theme is kind of a relaxation of the HIPAA or the privacy rules. So the links, take a look at them, especially if they are one of your payers. They will give you specific instructions on what that payer is doing. But again, I always recommend make sure that your documentation during this time is very good. So as we kind of come out of this, you can always, if there's any questions as to when and what was provided, you always have that documentation. So Joanna, I'll throw it back to you, but hopefully that kind of gave some common themes and an overview.
It does. Thank you, Patty. Appreciate that. So the next slide here, I'm going to turn it over to Chris to talk a little bit about some telehealth service visits.
Thank you. What sometimes we're seeing in our practices is the telehealth audio-video plan that we have in place doesn't always go perfect, whether it's a tech connect issue or some capacity concerns from our patient side. So what we've explored in our organization, our manager of our diabetes and endocrinology department, Lisa Raines, has identified, let's find a way so that we can use our telephone only. So this is using only the audio portion. We're able to connect with our patients, and we found that we are able as RDNs or RDs to capture some of that visit with 98966, 98967, 98967 and 98968 codes. Those are not intended to be DSMT. So I'll just kind of make sure I say that clearly. This is not intended to be used for DSMT nor for MNT, the audio-video opportunity we have with those two services as provided by the RD or RDN. These are simply an RDN access for a telephone only using an assessment and management service. This is something that can be found. A Medicare physician fee schedule was an opportunity. Now we can actually get paid under these in this COVID-19 opportunity we're having right now. And they're not to be used for providing MNT nor DSMT, but we can certainly use these to check in, especially with our CMS beneficiaries. Other payers, we would recommend checking, and again, checking with your organization if this is something that they feel is valuable. I will also preface this with it doesn't provide a very robust reimbursement, but it's a way to recover something. So, thank you.
Thank you, Chris. Next, I'm going to turn it over to Sasha for some information about what we know about FQHCs, rural health centers, and DSMT.
Hello. I just wanted to give a quick review because on many of our Q&As we've had multiple questions about FQHCs and rural health centers regarding DSMES or DSMT accredited or recognized programs. So FQHCs are federally qualified health centers and RHCs are rural health centers. In federally qualified health centers, reimbursement for 101 DSMT visits, you use G0108. That's your CPT code. And in rural health centers, the programs will add their 1-on-1 DSMT visits via G0108 to the rural health center cost report. So rural health centers are paid through an all-inclusive rate. So DSMT visits have the potential to increase the center's all-inclusive rate if that's not already capped. So they don't get individual payments for these, but this can increase potentially the rate that the health center's paid for any visit after that's reviewed over the next year. So then prior to COVID-19, the only telehealth services reimbursable to FQHCs and RHCs were the originating site charges. In other words, they could set a patient up in a room where they could interact via video conference with a provider from another site, which is called a distant site. But they had never had the approval to actually for providers at FQHCs and RHCs to provide those telehealth services like as distant site practitioners, like we've been talking about through these sessions. So all providers from FQHCs and RHCs have been excluded from Medicare reimbursement for telehealth services. However, the CARES Act passed on March 27th indicated that telehealth services may be provided by FQHCs and RHCs and reimbursed during the COVID-19 public health emergency, but they did not provide any further clarity. So we are still looking and waiting to hear if there is more information coming. And then the next question to recap is, can dietitians bill for DSMT without using modifiers or coding and just document it as telehealth in their chart note? So CMS requires that you bill for telehealth services using G0108 or G0109, adding the point of service modifier 11. That point of service modifier indicates that the service would have been provided in the office prior to COVID-19. The 95 modifier indicates the service was provided by a telehealth. They also are saying that providers can still use the POS 02 if they want to maintain their current billing practices. And then just an update, as our team had worked and talked with some others and collaborated with some other organizations, one of the questions we received in a previous Q&A was, is another referral required if providing one-on-one instead of group class due to COVID-19? And this relates to both MNT and DSMT. So this is a slight update that another referral is not required if group classes were indicated on the referral order, but please do document in the chart note that the visit was done one-on-one due to COVID-19 and no group classes available within 2 months. On this, aiming to reduce the burden on having to ask that provider to write another referral. And then finally, I'm going to pass this one over to Patty.
Yeah, so the question on can kind of an MD telehealth visit and a DSMT telehealth visit be billed on the same day? I'll kind of start with kind of historically, DSMT would not be paid separately if billed under the same MPI as a physician or advanced practitioner that was also billing an office visit. So now under kind of this COVID and the waivers, we have not seen any specific instruction that would change or remove that restriction. However, I will kind of state that obviously if the services are provided in person, that patient would not need to have come to your office and would not have, say, flexibility there with scheduling. But since they are being provided via telehealth, you and your provider may be able to schedule with that patient, always based on medical necessity, but it may be easier to do one visit one week and the next DSMT on a different day, etc. But again, have not seen any specific instruction that would waive what we've always known, that DSMT is typically not paid separately if billed under the same MPI as a physician billing an office visit.
Thank you, Patty. Just a few other slides just to share before we jump into the Q&A. As a reminder, there's multiple telehealth resources available, Medicare guidance, Center for Connected Health Policy reference sheet, HIPAA, and then the Academy of Nutrition and Dietetics resources. So all those links are available in the slide deck. And then also the Medicaid information. Different Medicaid information for different states. And then lastly, just a reminder about our call to action. We urge you to share your story with CMS to encourage them to allow RNs and pharmacists to facilitate DSMES services via telehealth during the COVID-19 pandemic. I know we have, been really trying to share this as much as possible, and we are really flooding their inbox, so I encourage you to participate in that as well. So let's get right to the questions because I see we have a few, and I want to make sure we cover as many as we can. So this one is for Patty. Can RNs bill for DSMES for commercial insurance?
So commercial insurance payers kind of follow the same as CMS, and they do not typically recognize an RN as an individual provider. So that RN can provide DSMT just as they can under CMS, but they would need to bill under an MPI of either a facility, physician, RD, or other qualified healthcare provider. RNs are not recognized as providers.
Thank you, Patty. All right, the next one I'm going to turn it over to Chris. The Medicare covering 98966 to 98968 codes, does that work for RDs in an outpatient hospital program?
So in the organization that I'm working in, yes, our hospital-based outpatient program, we utilize those codes as the RD is a recognized CMS provider. And the resource we used that was, and there's some pretty good robust stuff on the Academy of Nutrition and Dietetics webpage as we have in our slide resource deck. We can really see that there's an opportunity to be able to take that to your coding and billing specialist if that is something your organization wants to pursue. So that is specifically as it speaks to the CMS recognized provider as the RDN is.
Great, thank you. The next one is for Sasha. What verbiage is needed on the DSMT and MNT orders?
Okay, so I think if this is related to telehealth, the orders on our examples on the DAP website, we do have a couple examples for referrals, and there is an option for telehealth that can be selected. But I think as we were talking earlier, if a referral comes through for group classes through the EHR, through your normal channels, it's a matter of documenting in your chart note why the visit was done one-on-one versus group, or or if you were able to provide telehealth, that was for that reason.
Perfect, thank you. We're being asked for a little bit more clarification, Chris, on the explanation. Just a couple things. Can you explain more about what is being used or discussed on telephone assessment and management services? And can you use these outside of recognized programs?
So I'm going to answer that last one, using it outside of a recognized program. These are specifically speaking to what CMS has identified as the RDN as a non-physician provider. So they're really not necessarily to be indicated as tied into that program, but certainly as the assessment and management of the code indicates, it can be used as a follow-up. And there is some specificities to the length of time. It needs to be at least 7 days after an MNT intervention. I think the reason that these codes were being identified as an opportunity is because RDNs recognized as a non-physician provider and the specific service that RDNs are intending, the MNT. So you might not really want to be using it. I personally, as an RDN, I would not be documenting as though it was a DSMT session. I wouldn't be considering I'm following all of those, the cycle of the DSMT, but I would be following up with my patient as far as an assessment of some specifics to maybe medication, addressing a change in medication or a change in regimen, change in their situation or lifestyle that supports the patient, probably more accommodating to MNT.
Thank you. All right, Patty, we have a few for you. Do RNs need to be physically in the clinic if they are providing DSMT at this time, billing under incident to the provider?
So DSMT is never billed as incident to. That is a separate benefit. And I'm not sure quite, yeah, so that is not considered incident to. If I'm understanding your question, if the RN for some reason is in a physician's office rather than being closed, which most are, then that, again, we still have the restriction of that RN be able to provide telehealth. CMS has not yet clarified that today RNs or pharmacists are not currently recognized to provide telehealth. So I don't know if I quite understood the question there, but hopefully I answered it.
Okay.
Yeah.
And then another one, yeah. And if we need, we may get some, clarification if they want to expand on that one. But then another one for you is our outpatient department is located in our hospital and billed under the hospital's NPI. Can we bill for DSMT telehealth under the hospital's NPI? Finance is telling us we can't.
So DSMT continues to be billed under the MPI of the accredited program. In this instance, I think the question is, has that outpatient DSMT program been billing on a UB04 or the CMS 1500? We've had lots of discussions that today CMS has said that DSMT cannot be billed on a UB04 via telehealth. Now, if that outpatient center is billing on a CMS 1500 and has been billing under a CMS 1500, then that may be allowed under telehealth. And Leslie, correct, feel free to add in if you have anything else to add to that.
Sorry.
Okay.
No, Patty, I think you covered that well. It's an important distinguishing factor that came out recently. We're still hoping for more on other areas, but that one was pretty clear.
Okay.
And then, Patty, it looks like just a little bit more clarification is needed. Can RNs bill to a commercial insurance for telehealth using the hospital NPI number? I think that might be similar than the above question, but I'm just going to make sure it's covered here.
Okay, so an RN is not typically recognized as a provider. So the RN would never bill via telehealth or in person, typically to a commercial payer under an MPI of an RN. I think if the question comes here is does commercial payers differ from CMS in the sense that that commercial payer may recognize that RN or pharmacist as a team member that can provide services via telehealth. The billing is still going to be done under the program, not the RN. Then I would recommend that you contact your commercial payers. As you know, each commercial payer can kind of make their own decision. But I will also say I have not seen anything in writing that says under the commercial payers that would preclude an RN as part of an accredited team being able to provide that. But again, some payers are going to follow CMS, and CMS has been very clear on who is a provider that currently can provide telehealth services.
Okay, thank you, Patty. One more for you before I go to Sasha. Can you clarify if RD is providing DSMT via telehealth? Are they able to bill for 2 hours MNT and 2 hours DSMES a year for an established patient at this time?
So with the appropriate referrals, yes. Under these waivers, the number of hours that are allowed has not changed. So if that patient was eligible for 2 hours of the DSMT as well as 2 hours of the MNT, and all other criteria is being followed, then yes, those could be provided by the RD via telehealth.
Okay, thank you so much. Sasha, are you available?
Yes, can you hear me?
Okay, good. I knew Sasha had a technical difficulty, so I wanted to make sure she was with us. Okay, as a private practitioner, can I use MNT CPT codes, or do I need to use the GO 109 code even though I'm not an accredited DSME program as of yet?
So that's a good question. You will be using, as an RD, you'd be using your MNT codes for medical nutrition therapy, and you will not be able to use those DSMT codes, G0108 and G0109, until you become accredited and receive that certificate. And the process is once you receive your accreditation, you will get your certificate, and then you send that to your Medicare administrative contractor and or your billing person so that you become established as a program with accreditation. And then that is when you are allowed to bill.
Perfect, thank you. And then Patty, one more for you. Thinking about the referral form, and we talked a little bit about this earlier, so are you saying that we're not required to specify telehealth on the orders moving forward on a referral?
So in this case, I think, you know, some of the if it's, and Leslie, please help me, these questions can be hard. So if they have a referral for DSMT or MNT, and due to kind of the COVID crisis, they're now providing all of that by telehealth. I have not seen that you'd have to have a new criteria for telehealth. Leslie, do you agree with that?
I do, Patty. I mean, okay. I'm wondering if the question is going back to the fact that there's 2 hours follow-up every year, because it's odd that we chose specifically 2 hours for each. If you could, whoever asked that question, if you could clarify that in the inbox, we would appreciate it.
Perfect. Thank you. And then, Chris, this one's for you. Can you describe best practices in teaching new injectables via a virtual visit? What are the resources that are needed by the diabetes care and education specialist and the person with diabetes?
Sure. I think you put your mind into the place where if the patient were right there in the office with you. So I find it best practice to see if my patient can bring their whatever their prescription is, their injectable device with them, so we can do the teaching in real time and they can do their first injection in the office if that's the appropriate time. And in thinking ahead to that, you could ask the patient to have their prescription ready and ready to go, have their device ready if that's appropriate timing. But I get my tools ready. I'll use a squeeze ball as my pretend human and get my device using my camera, I'm able to zoom right in and show where to look for expiration date, what to look for in terms of the view window on the device, if it's a dial, or how it might actually, just depends on whichever their product is they're using. So I really zoom in on my camera. I'm able to see what I'm doing with that and verify that the patient can see it. And again, if the patient has their device in real time, have them tell me, what is your expiration date? What do you see? What does it say, U100? Having them explain to me what they're seeing, and then, is necessary, putting on the the needle tip or what have you. So having the patient prepared. If I'm able to get materials to the patient ahead of time in terms of those teaching resources, I do that. If not, I've mailed out or showed them on my desktop view the stepwise written resources that I would have usually given them in person. So same practice.
Thank you so much. And then this is one last question for Patty before we wrap up. Please comment on the difference of DSMT and CCM where pharmacists may provide services under collaborative practice agreement for management of chronic disease, includes diabetes.
Sure. So DSMT and chronic care management are two very different services. Chronic care management has been available for the last 2.5 years. That has always been performed remotely. Diabetes can be one of the two chronic diseases that would make a patient eligible for chronic care management. But again, that is not specific to DSMT. And yes, staff time, such as an RN or pharmacist, can count towards that 20 minutes or 40 minutes that would be used to bill chronic care management. But again, that is not intended specific to DSMT. It is for other chronic diseases such as COPD, heart failure, etc. Again, some criteria for chronic care management is that your physician probably already would have a chronic care management agreement with that patient. And why I state it that way is that patient has to agree to receive chronic care management. They have to have a dedicated kind of physician. Patient must meet the 2 chronic diseases, et cetera, et cetera. So if you have been providing chronic care management, continue to do so, but that does not per se kind of change any of kind of things that we've covered specific to DSMT.
Great, thank you, Patty. And thank you to everyone who was a presenter answering questions with us today, and then also to all of you that participated in our Q&A session. Just as a reminder, please go to our My AADE Network discussion. The link is on this last slide here. And then also remember that we have a Q&A document, and we keep that document updated. And so just make sure you check the date on it so you can see when it was recently updated based on any new rules that have been released, et cetera. And you can find that on our website as well. And just we will be back here the same time next week until the end of April, and then we'll kind of reevaluate and possibly do more if needed. But I'm going to go ahead and wrap up and allow Megan to close us out.
Great. Thanks, Joanne. As she mentioned, we have that link to the My AADE Network discussion on this screen. And also under the web links box, you can go directly to the resource page mentioned. And again, you can download a copy of today's slides where you'll have access to all the links that were shared in the download slides PDF box. And we will leave the webinar room open for a bit to give you a chance to download those slides and check out the links. So thank you, everyone. This concludes today's presentation.